Hello and welcome back to the Neurotransmitters. I am your host, Dr. Michael Kentris, and today I am, as always, excited to introduce our guest who will be talking about medical education in neurology, a topic, obviously, if you've been listening to this podcast, that is very near and dear to my heart. So to help us with that journey today, we have Dr. Galina Gheihman, an instructor in neurology at Harvard Medical School and a neurologist at the Massachusetts General Hospital and Brigham and Women's Hospital in Boston, Massachusetts. Galina, thank you so much for joining me today.
Michael, thank you so much for having me. It's really an honor to be on the Neurotransmitter podcast and have a chance to talk with you. I'm really excited as well.
Awesome. So I had the opportunity to meet you last fall or spring. God, the season has just run together. At the American Academy of Neurology. And it was very interesting because you were part of a group that were doing some very new and interesting things in neurology education. But before we get to that, why don't you give us a little bit of your background and what led you kind of into this somewhat niche area of neurology?
Sure. Thanks for asking. So I guess I've been interested in education for a while. I always, even back in middle school and high school was kind of like the one who would tutor other students or help others out and was always interested in making material more memorable. I studied like biology. I had a friend who was better at physics, so I taught him biology. He taught me physics. And so that kind of peer learning and peer support was something that I even thought about a long time before. When I got to medical school, I also experienced a very innovative curriculum. The case-based collaborative learning curriculum at Harvard Medical School at the time basically required pre-preparation, sort of like a flipped classroom model. And then in the classroom, essentially, you learn from your peers. You had support and facilitation by our instructors, but it was very engaged, active type of learning. And I found it to be both exciting and also quite empowering as a learner because it was self-directed, it was team-based, and it kind of was really clinically relevant. Like it was all based, it wasn't sitting in lectures listening to, how serotonin is formed, but it was really like, what do we do with this patient who has MS and how do we treat them? And then we would sort of dive into the neurosciences as needed. So on the background of that context, I felt like there was almost like a kind of the fourth, wall was lifted in terms of education because the medical school was undergoing that change actively and they encouraged us as students to be involved. We called it sort of like the co-production of education between faculty and students. And so kind of like whether you wanted to be a medical educator or not, you were part of this process. It was being co-created. And then those of us who had an interest in medical education, I think kind of got swept into that process a little bit more concretely. I also count myself lucky because I was interested in a project related to longitudinal clinical education, joined this project, and then the senior mentor on that project is someone who's one of my closest mentors in medical education, Dr. David Hirsch, not in neurology and internal medicine, but one of the leaders in the world actually are related to longitudinal clinical experiences and research in that. And so by first year of medical school, I was working and starting to do research in education, educational structures and evaluation. And really, if anything, I feel like I found education before I found neurology. So that was really a thread that I pulled through into my residency and was very happy to see that neurologists were very receptive to the learning organ and to the concepts of education. So kind of high speed across a couple of years, but as a resident, I continued to be involved in educational experiences. And in particular, I sort of distinguish it. It wasn't just teaching, but it was really this idea of trying to get into educational scholarship. So that creating new programs, evaluating those programs, publishing on medical education. And so thinking a little bit more higher levels than just the bedside teaching and the peer-to-peer teaching, but really thinking around like, how do we deliver programs and how do we adapt them to different learners? This journey has led me to meet many mentors, network with others in the field, get involved with lots of experiences, and most recently has sort of culminated in the co-creation with a group of other organizers of the Neurology Education Room, which you referenced. And what we envisioned actually 2 years ago when we first came up with this idea was really a place where people like us, those interested in neurology education, could gather meet and network. And so I can go into it a little bit more if you want to hear more. But in terms of my background, I think it's a lot of, braided together threads. One thread being a long-term interest in teaching, a second thread being kind of, I think, the circumstantial experiences, honestly, of my medical school training and how transformational the curriculum change had been, and really seeing the impact of that and trying to think about creating that for others. And I'd say the last thread is just like deep principles of education that matter to me, things like mentorship and person development and kind of like helping people reach their potential, I think is like ultimately my goal. And education seems like a really incredible means to do that. So that's what drives me forward.
Excellent. Yeah. I know personally, my mom is a school teacher, so I definitely had that element of like education is good, as a formative
Yes.
household experience, like through my childhood and, teen years. And like you, I did some tutoring in college as well. And it is one of those things where you kind of get, a lot of fulfillment from it. And maybe it's just me moving, kind of more towards my middle career years, but I am seeing this push, or maybe I'm just becoming more aware of it, where we're seeing some more rigorous, as you said, research about the actual theory of education in neurology specifically, and I think to an extent in medical education kind of at large. And, I'm certainly not a theorist. I don't have a master's of education or any formal training. So it's just kind of what I pick up off the streets. But it's very interesting because it seems like there is a big push towards kind of quote unquote educating the educators. And I'm kind of curious, like because that's I wasn't able to attend all the sessions at the AAN's education program, but the ones I did, it definitely felt like there was a very collaborative spirit there, and people kind of comparing what they're doing at these different institutions across the country, and both in the undergraduate and graduate medical education sphere, kind of looking at like what are people's experiences, what are the things that have been successful, both on a administrative as well as kind of a educational side of thing.
Yeah, you make a great observation. And I think that we're experiencing is kind of the natural evolution of a field to higher quality. Like our ultimate goal is higher quality learning because that will lead to higher quality care. And so the fact is that like as learning science evolves, like as we learn more about how we learn, there has to be kind of this like a subsequent evolution in how we teach. And I think it's Dr. Roystrud who says like, learning is an evidence-based science, like just like medicine. And while we accept a lot of kind of, time-honored traditions, where we use evidence. And I think that education is no different. It's like we can accept some time-honored traditions, some things that we're doing, but it sort of behooves us as, experts in teaching to also use evidence where we can. The other analogy I would make is I feel like it's the Olympics now. And you know how people always say like, well, people's bodies haven't really changed in many years, but like the technology has changed, right? Like they can wear extra swimsuits and the coaching has changed. And what's really different now is that the way, the swim coach's coach is different. And that's what's really making swimmers better. I think the analogy is similar to what we can do to make our learners of higher quality and our education of higher quality. And this is the idea that we could help those who are in the teaching position to teach and coach better. And we actually know how to do that. And so our idea is kind of I'll just say neurology, I'll keep it to neurology, but it's really true for all medical educators, have a duty to teach. We teach our patients. We teach our trainees. I mean, the entire medical model is precedented on an apprenticeship model. So it's not like we're saying something novel. We're just saying, can we take this model? We accept it, but can we take it and accelerate in areas where evidence exists? So, we know what's effective in bedside teaching. We know about different motivational theories for students. We know about like, if we're going to use technology, here's how it might be most useful, or how to structure objectives, or how to structure evaluations. And so while I don't want it to be so structured that it maybe turns away people who don't have that experience, I think what we tried to create was just a place where you can begin that conversation. So like if you just want to use the best evidence, like you can use someone else's cases. Like you can kind of come and say, oh, great, I also want to do simulation. Well, you don't have to reinvent the wheel. We could have a collaborative across the US, for example, or internationally. That's like, here's a database of simulation cases that are vetted, peer reviewed, that you can use. And here's how you do it. So just the same as you, prior to us recording, you had said, I had a complex case. I called a specialist. I'm envisioning that we could have education specialists. So maybe you're interested in teaching this topic and you call, myself or a colleague and you're like, hey, I really want to improve our EEG curriculum. Well, here's a set module. Here's like a set module I've studied. It has these outcomes. It's for this type of learner. You can use it or you can adapt it to your learner and again, study it and see if it stays valid and stays rigorous. So that's the idea, is I think kind of lifting the quality of all boats and focusing not so much on the end learner, but actually a step upstream of that, of how do we coach the coachers, educate the educators, at least where we have evidence, and support them in kind of moving the higher quality of our education forward within our field. I'll say one more point, which is that, so a lot of the time, the audience matters. So you mentioned undergrad versus graduate medical education versus other learners. They're going to need different approaches. The undergraduate learner, there may be a little bit more integration with basic neurosciences. There may be integration across disciplines. The resident fellow, they're going to want detailed clinical information, as well as thinking around clinical reasoning, management, follow-up. When we teach other learners, for example, a growing population within neurology is advanced practice providers who are entering our field. It's a different audience. They have a different training background than residents, for example, even if they may be performing similar duties. And so even just the little questions of who is my learner, what are my objectives, and how will I know if we've been successful in that? Like that framework of an educational mindset is something that we want to empower people to have and think about as they design their teaching or their training, whatever that looks like.
Yeah. And that's, that anecdotally, that experience is kind of what has guided me a little bit as I fumble through the dark. I was at a small teaching program for neurology.
Come see the light. No need to fumble in the dark.
Yeah, so I was, an instructor at a neurology residency at Wright State University for a few years, and there I was mostly doing like neurophysiology instruction, like EEGs primarily, and kind of some general neurology stuff. But then we moved, and so I'm at a community teaching hospital. And here we have more internal medicine, family medicine, emergency, general surgery, etc. So my learners have changed significantly, right? I'm not teaching these neurologist-specific skills anymore. So I had to think, like, what do I think it's important for an internist to know as they go into practice, or a family medicine doctor? And can I, with the limited time, with all the other things they have to learn, how can I get their attention, right? Because obviously those of us who are in the know about, neurophobia and these kind of antipathy towards neurology as a practice. Like, I don't want to know about that. It's confusing. Get out of here. And so how can I make it interesting and approachable and make it so that these people are comfortable with managing some of these common complaints? Like, for instance, the Alzheimer's conference is going on this week as well, and there was a big announcement in JAMA about this new biomarker for diagnosing Alzheimer's disease. What kind of can of worms is that going to do, right? Is this going to be like, is Alzheimer's managed by primary care now? Right? Big questions, big shifts happening, and it's just one of these continuing evolutions of what can we, because there, right? We all know there aren't enough neurologists. So how can I educate these people, my colleagues, my future colleagues, so that they're able to handle some of these more, hopefully, straightforward cases, like headaches or TIAs or things like that, where maybe they don't have a neurologist on staff. And it's one of those things where I've been kind of, for the last 3 years, just been iterating on this and trying to find something that works. And some successes, some failures, and it's a constant process, right?
I mean, the work you're doing is so commendable and so important because there's no way. I think there's data on like the shortfall of neurologists that are anticipated in the coming years, and we are going to have to share the burden and the load for patients with neurological symptoms and complaints. I wanted to point out one aspect, which is, you shared that your task has been to iterate your curriculum. We can call it a curriculum for your audience. And so my interest is sort of like one step removed. It's kind of like, how do I help the Michael Kentrises of the world, like out there? Like, what is it that would help you to be more, structured in your approach, or to be more effective in your approach, for example? And not just me helping you directly, but like, who is it that you need to talk to? Like, and maybe there's a forum where, hey, it turns out there's, similar people trying to do similar things in their communities. And maybe your EEG module, which I guess probably is not less relevant for this audience, but let's say your stroke module would be of great use to like some other neurologist in a community who has that interest, but maybe hasn't developed those slides. And so that's part of this idea, is that, I feel like it's just a lens to what we're already doing, the lens being education or teaching, but it's also can be quite clinical and can be quite useful. And the idea here is just to augment those efforts, like having you as you sit as the educator, like matching you to the others sitting at your level as the educator, and having you guys be the network that then has spokes and kind of from there.
Yeah, and I've seen some things being written about this, maybe not in journals, but online and kind of from personal experiences, where there is so much good medical education material out there, but it's so fragmented across institutions
Mm-hmm.
or different platforms or things like that. I know there are some hardy souls out there who have been undertaking that. I apologize. I think it was Aaron Zolikovich. I might be mispronouncing his name, but I know he's been collecting a lot of neurology education resources recently.
Yes.
And they're making some pretty impressive progress there. And I think it's one of those things where, like you were saying earlier, these cross-institutional collaborations can be very helpful. And we see, like, historically in the neurology sphere, the oh God, I'm terrible pronouncing these names, for the Piffen Henry, the epilepsy teaching course, and then there's the movement disorders teaching course, which has a bunch of experts from across the country doing these virtual lectures. I really think one of the, if you want to call it a good thing that came out of COVID, has been this increase in this kind of online cross-institutional collaboration for a lot of these more niche topics, so that they're able to reach these residents who might not have exposure to certain things. I know certainly, 5-7 years ago when I was in training, it's getting longer, but it's things that weren't available. I know that sometimes I would make a trip down to Cincinnati, which was like an hour drive, when I got down there a handful of times during residency, and I'd be able to listen to their movement disorders panel talk about all these bizarre cases. But, the residents who were there were able to go, like every month. So it's one of those things where maybe you don't have these things available at your institution, whether that is for neurologists specifically, or there's a lot of family medicine programs or internal medicine programs out there that maybe have one staff neurologist, at the hospital. And, as you were intimating, perhaps not directly, some people are more invested in education and might have better or lesser skills for education, depending on their particular enjoyment of it. So we probably have hundreds to thousands of physicians going into like primary care, things like that, who may have very minimal neurology background.
Yeah. So a few comments with regard to teaching skill. Certainly, that varies, but I believe it's teachable. so my belief is that it can improve with practice,
Yes.
and it can improve with coaching. And even someone has a lecture. Let's say, okay, let's sit down. Let's have a conversation about how to make this lecture more interactive. How to use principle, like even simple tweaks and changes. Start with a case, or start with the student's own experience. Get them invested. and then go into like your 40 minutes of lecture, or change the whole idea. You have 40 minutes, but no one said it had to be a lecture. So just trying to get people to be a little more creative within educational structures, and then with how they deliver content. I agree with you. I think that the explosion of online resources and sort of the democratization of access to neurology and neurology education really did change with COVID. It was sort of the, golden age of like the med Twitter and like the neuro Twitter. And there's a lot of folks like Casey Altman comes to mind, and Aaron Berkowitz, were superb kind of leaders on the tweetorial front, who've actually done research looking at like the impact of those and the impact on their careers and the impact on connecting. I'm also very fortunate to be part of the resident and fellow section of the Neurology Journal. And that's a section that has an editorial board made primarily of residents as well as some fellows. We have a 3-year term, so you have some continuity, and we work with the editors to peer review cases and do help with the publications. But what's the unique slant of that section is that really the purpose of it is education and teaching. And so when you submit a case report, it's not novelty that matters, but like what's the teaching point? And so that's been a really great immersive environment to be in. But it's been surprising to me like how few people know about us as a resource. Medical students don't like go to the RFS, residents don't necessarily go to the RFS. And so I think one of the big challenges we have in education is, one, the collection of resources, which Aaron is working on. He's one of our editorial board members actually as well. But two, kind of like almost I would say the curation for a learner of these experiences. Like I can imagine, I totally understand that I'm sitting like within the richness of the Mass General breakout system. We have, like you said, movement rounds and epilepsy rounds. There's too many rounds to go to, versus someone else who doesn't have that access to them. Like that, RFS case of some rare disease might be some beacon that's like, hey, like I read about this. I know about this. I'm interested. And I think having that like humility, that perspective is very helpful. And I think that happens when you gather and when you get to talk to others. And being part of the RFS, we have global members who are just like, no, these cases are like that. This is like why I went into neurology. Like we don't even have a neurologist in my country, like let alone like, my city or my block.
Mm-hmm. Right.
And it's exciting to think about how we can, one, spread what we have here and like spread that wealth, but also how do we kind of bring the wealth of those diverse experiences like here?
Yeah. And I've been seeing more like on the neurology blog section and things like that of people writing about those experiences, which are always very eye-opening. Like you said, people from countries in Africa or the subcontinent or things like that. And, just my own conversations with people from those areas or even South America. And they're really doing some impressive work with significantly less resources than what we have in most of the parts of the U.S. And it's one of those things where we're seeing these people making these kind of Herculean efforts to both educate themselves as well as their peers, and it's very impressive in a lot of ways.
If you think about the impact one can have, arguably you could have more impact as an educator. Like if you could deliver an effective intervention, I'll say intervention because I don't know that it's a Zoom lecture, but even a Zoom lecture would help to a group of clinicians in a different country. Like you could potentially augment the care that they're able to provide to their patients. If, when we think about volunteer and service, like I think it's very appealing to go and like have your hands on the patients and talk, and maybe it's a combination that there's, you build a relationship through annual visits and then you've got a lecture series as well. But thinking around like tenfold, hundredfold, thousandfold, like how are you going to have an impact? It's really in educating that next generation coming behind you and coming up and those around you. That's the only way we're able to scale high quality neurological care. So I kind of feel like maybe I'm a neuro advocate or a neuro evangelist, as someone once called me, and which I wasn't sure if I was flattered or complimented. But this idea is that, education can solve so many of the big problems we face in neurology. It can help with access. It can help with higher quality care. It can help with our training. It can, because education is a tool, you can move it to where what your target is, right? If your target is well-being, okay, well, let's redesign our programs. If your target is clinical care, that's a different story. If your target is quality and safety, okay, great. You've identified a morbidity case. Like, how are you going to change things? You're going to educate people, right? So it's kind of like always going to be part and parcel to any iterative improvement we want to make. And my thought is kind of taking that educational mindset, thinking around what's my audience, what are the objectives, what will be the design of the methods of teaching to get to those objectives, and then how will I actually know that I've been successful? I think there's a lot of parallels between quality improvement and education, in the sense that you have an aim, you have an objective, you have some kind of ideally measured getting there, you can improve iteratively. And so I didn't mention this in my brief bio, but I have a little bit of a background in QI. And I think that I blend those perspectives when I think much more around an educational stance or an educational mindset, like kind of like as you approach a problem, you don't have to have all the full rigor of like every single thing I do has to be, a complete like art, like randomized study with like this many controls and a perfect data plan. But can you at least invoke those questions as you begin a new innovation and think a little around like, how will I know it's working? What feedback will I get? How will I interact with my learners? And those are some of the principles that I like to, what I would want people to take away. Not that it's all or nothing. It's, completely random teaching off the side of like your desk versus like it's a completely rigorous thing, but that there's this big gray area in between. And if we can even shift a little bit towards some more scholarship, that means that one, as a teacher, could be a little bit more effective. Like, for example, say you're using a known validated simulation case. So you've decided I'm going to simulate, I'm going to give my learners an opportunity to practice stroke care. Well, you can use a validated case. So there you go. You've like one step up the ladder. You want to go a step higher. Maybe you'll also survey your residents and add to the literature. And so if all of us just have a little bit, like one step up from where we are now, we're actually contributing in parallel to the literature as we're contributing to the learning. The analogy I would say is sort of like clinical research. There's a lot of clinical researchers, especially in rare diseases. I saw a talk recently and the presenter had a big slide and he was like, every patient with X condition should be in a clinical trial. And his point was that we're losing the opportunity to gather data. Of course, you have to consult the patient, all that. But his point being that, every interaction in his case between that clinical drug and the patient was informing this area that's in need of greater research. And I think education is the same, is that we have an opportunity to make sure that every learner is in some way helping us contribute to accelerating overall our field of neurology education.
Yeah, that's a lot to take in. So one of the things I sometimes, and this is probably more of like maybe a epistemology type question, is right, because how do we measure a success of our intervention? I know some of the studies and things that we look at, right? We look at maybe pre and post test performance, or like you said, surveys that are often looking at things like confidence of the learner in managing X condition, things like that. And we don't necessarily know how well that translates to like actual patient care. At least I'm not aware of anything that shows like a direct correlation. But what are your thoughts about that in terms of like kind of the limitations, like you said, of like our measurement of improvement?
Yeah, that's a great question. It's a real like sticky point for education research. There's a concept called the Kirkpatrick levels of outcomes. You may or may not be familiar with, where there's a scheme of kind of levels 1 through 4, and each are considered of higher impact. Level 1 is that like reaction to the intervention, like, oh, were they satisfied? Did they like it? Like it was well organized. I like that it was at 3 p.m. on a Tuesday and not in the evening. The next level is kind of knowledge, like do are they able to apply the knowledge? So for example, you might have a post-test. Level 3 is behavior. So, okay, they did the post-test, and then when you saw them in clinic, they did in fact order, nortriptyline for migraines as opposed to like Tylenol, which they used to order. And then number 4 is outcome. That's the highest level outcome of the patient. So like after this intervention, a year later, all the migraine patients had the right diagnosis in their note, and they were all on a preventative medication if that was indicated. So I think what we have not had in neurology education as well throughout the past is sort of this ability to push the outcomes, as they say, push up the level of Kirkpatrick's evaluation outcomes. I am optimistic because I think like this whole AI ChatGPT, like scrubbing the Epic, Epic is our EHR. So like scrubbing the EHR may create an opportunity to marry like clinical outcomes and educational outcomes in a way that we haven't seen before. So one idea is this, that, could we create an intervention and then kind of use like data from the medical record as evidence that a learner is implementing what they're learning? Like how are their and I don't know that notes are really the best measure, but like, are there differential changing? Is the problem list changing? Is the time to a preventative migraine medication changing? Like, is the number of neurology consults going down, which may or may not be a good measure. It's got a pros and cons, but in the sense of, or maybe are those consult questions of higher quality as rated by, say, a subjective measure, but nonetheless rated by 2 to 3 neurologists is like, yes, this is a clear question as opposed to no. Or so I think every measure and every study is going to have every change will have pros, cons, and kind of unexpected outcomes. But I do think that we should push ourselves to try to get up that hierarchy, and I think leaning into new technologies may help us do that.
No, I think that's a great thought. And certainly, I know there's a lot of effort being made to integrate AI into a lot of different electronic records. And it'll certainly be a brave new world once that happens.
What's really exciting is actually in the neurology education room this year, one of the sessions we had, because one of the drives behind this education room was, number one, as I said, bring people together and help them meet one another, but also create like a catalyst for collaboration opportunities. And so we had a really innovative session. It was called the Reverse Shark Tank. And really what it was that there were, I think, 5 participants who pitched their research project and said, hey, join my project. Like, my project is so cool. I need help. And one of the people, Dr. Rachel Gottlieb Smith, I think I'll get her name right. And she pitched, essentially, they're doing like she's a pediatric neurologist. So they're focusing on pediatric neuro, and they're doing a like clinical informatics informed educational intervention where they're basically like looking at what residents are seeing in clinic and what they're seeing on the wards, and like using that like documented data to sort of create a tailored curriculum plan. Like, hey, you saw these things last week. Like, here's what reading points, or like, you haven't seen these things. So I'm going to feed you more training or more questions. And I think a step 2, they have a plan where they will essentially like have a kind of scorecard of what residents are seeing, and then like book clinic patients based on like where they're lacking, because they have a way to kind of essentially use AI to review the record, create a educational scorecard, and then like adapt and tailor the teaching. So it's like precision informed education. I'm probably getting the details wrong. We'll have to ask Rachel to clarify, but she presented this, and there were so many people jumping on board, mostly adult neurologists being like, when is this coming to adult neuro? And the decision, I think, was made to start first in pediatrics and then expand. But what was really cool to see was, one, the huge appetite for this, like program directors being like, sign me up, right? Like, and this opportunity that she could augment what she's doing by doing it at multiple institutions, proving from the get-go it's a multi-institutional effort, it's feasible, implementable, adaptable. She has larger N numbers to get at the outcome of this being, a valid measure. And she was able to garner more expertise. So, for example, one person pointed out that, hey, well, what about the faculty who are going to have to meet with these residents and review these report cards? Like, what is faculty development going to look like for this? Someone else was like, you should really do some, qualitative research, like with these residents. And she's like, oh, that's not a skill set maybe she has, but or actually she does have qualitative research experience, but like kind of gathering people who were going to fit into a little project. And I think for me, it was very exciting to see what I think are the sparks of what it must have felt like 100 years ago when clinical trials were first starting and people were thinking about like platform trials and like we had site PIs. And I remember Dr. Galina, Stephen Galina, who was organizing, is standing up and, introducing this Shark Tank. And I just felt like I was like a new era is starting in education. It's like, we're going to have like a site PI. We're going to have like site coordinators. We're going to have cross-institutional work. We're going to be able to gather, data in a different way. And I think it's all the early stages, but I'm really hoping that, looking back in 50 years, some of us would say like we were at the beginning of it.
Yeah. It really sparked some thoughts because, like you said earlier, right? Medicine, traditionally, it's an apprenticeship model. And so it's one of those things where you're in residency training for so many years, fellowship training for so many years, if you decide to go that path. And you become most intimately familiar with those things that you see and manage. And it is really one of those things where if you are able to find those gaps, like, oh, I haven't seen, XYZ rare diseases, it's like, well, you need to spend time with the geneticist or the movement specialist or whomever, and we're going to slot you an extra week into your training schedule to supplement that shortcoming so that you get these skills. And I think that is just fascinating to be able to do that with that kind of precision potentially. And it really is interesting because I know, and probably a lot of people listening, it's like you hear about, we've got this strange case of such and such, over on the neurology unit. And maybe you stop by with the rounding team, even if you're not on service that day, just to see the case. So you see what's going on, you kind of get familiar with it a little bit, even if you're not the one taking care of it. But, time is limited and sometimes you can get there, sometimes you can't. Not everyone is that motivated. So sometimes there does have to be a little bit of a force feeding involved. But yeah, it's very fascinating if that's able to bear that kind of fruit in the education experience. I think it'll, like you said, really revolutionize things.
I think time will tell. Yeah, I think you're right that we'll see what's effective, and what's effective will probably stick. I think what you're saying about the different goals is super important too. There's like a reason I think we have specialization, and it probably is like that higher order refined diagnostic approach. But let's say, like you and I are both general neurologists, there's, a certain skill set to saying which specialty does this go to? Like, is this movement? Is this, or is this a neuromuscular problem? Like if a patient says I'm weak in the leg, well, is it stiff, or is it like, what's the issue here? So, or is it just like sensory ataxia? I don't know. Like, it's interesting for us. And so thinking a little bit around like kind of what is the knowledge point that you're trying to transfer, and being adaptable in that, and not just like, here's my set thing that I say, but like if I'm talking to, I'm talking to neurologists, like the approach to weakness talk is going to be very different than if you're talking to, as you said, like a internal medicine resident or someone else. And I think that being able to give someone, I would say, much more transferable skills is important. So what I mean by that is, for example, in neurology, our exam matters a lot, and how you perform does matter. But even if you don't know the specific terms, like being descriptive is something that I would teach someone, is like describe, the amplitude, the frequency of the tremor, like how it changes and even if you don't know the terms, like it's actually more useful. I often find when I get transfer calls, it's like, oh, there's a chorea. You're like, what does it look like? And they're like, oh, you mean it's more like a tic, or it's more like a tremor, or like it's like, I have no idea. So we have a series that we lovingly call Movement After Dark for our residents. It's an elective like dinner series with a video submitted by residents, pre-reviewed by the fellow and attending for some teaching points, but everyone goes around the room and practices describing the phenomenology. And that's a very clear objective of the series. It's not like, oh, got it, like that's, Huntington's chorea. It's more like, this is a patient, like, what do we observe? We watch the video. Is it symmetric? Is it asymmetric? Is it one limb? Is it multiple limbs? Does it involve the face? Like how frequent? What does it happen? And I think that kind of skill set of like, not jumping to the answer, but learning frameworks of an approach is, I think, what is most useful to the generalizable learner. It's the same as if you have an intern at a business. Like, yes, your business might sell cars, but if you can teach them like to manage a calendar, to manage their time, to like know about how to customer service, like that's something they can take to their next job. And that's kind of an investment in the learner outside of your specific need for their role. And so I think that we, as educators, I would like to push us to kind of think a little bit around not just like, did I transmit this knowledge? Like, did I transmit like these 4 seizure medications? But more like, did I help develop the learner and give them a skill set that they can take away beyond the session that we talked about today? And often that depends on the kind of teacher you are. It's funny, there's actually teacher scales and like kind of quote unquote teacher personality tests you can take. I've done this in teacher training courses, and people vary. There's one type that some people are very high in knowledge transmission. Like that's their number one objective. Others are a little bit more around coaching. Some are about more professional, like kind of personal development of the learners, relationship building. So I know that's my bias. I'm a little on the relationship building side of seeing my learners evolve and become kind of independent rather than transmitting a specific learning point. But I think even among us educators, in our collective impact can be across these domains, not just the knowledge translation, but the development of the learner into kind of their own, lifelong learner is what I think we want to support.
Yes. You have to kindle that curiosity. And it's very funny. I remember when I was a fellow, we would do a lot of like epilepsy video reviews and stuff like that. And it was that exact same thing. I think epilepsy and movement have a lot of similarity in that particular respect, although they call it phenomenology and we call it semiology, but that's okay. Two specialties divided by a common language. But it is one of those things where like I was literally like everything you were just saying was like hitting me home. I was ranting to the internal medicine resident just this last week about like you have to train your mind to recognize what your eyes are seeing, right? Because obviously I do a lot of inpatient work, and probably the second most consult we get after like altered mental status and stroke, I guess that'd be number 3, is quote unquote seizure-like activity. And so really like getting into the nitty gritty, or if, even have a video, like literally this last month, I was, shouted, from like the nurse. I was 2 beds down the hallway, and it's like, oh, the patient's having a seizure. And we come in and like, oh, the patient's, having irregular jerking, side to side movements, pelvic thrusting, right? And it's like, oh, this does not look epileptic. And, we kind of kept an eye on her and stopped in 2 minutes. And, it was pretty clearly not an epileptic seizure. And, we didn't give her benzos or anything. So we were able to avoid those negative interventions. But if she had called like sort of a rapid response team, then the ICU team comes up and all this kind of stuff. And maybe people who aren't as familiar and they don't recognize what is a non-epileptic versus an epileptic seizure. And right, it's this whole thing where you just want them to recognize, like I give a lecture probably once a year or so, and it's just a series of videos. And the only question is this an epileptic seizure or not? And then we go into the why for each video. And most of the time, people are about 50-50. It's about like 6-7 videos. And it is one of those things, right? Where it's like, this is like for us as a neurologist, this is like fundamental skill set. And like people in other specialties are just really bad at it. And I haven't found, it's something I've been plugging away at just to like figure out like what's going on here. And when you see like all the papers out there, like the rates of intubation for non-epileptic events is going up over the last like 20, 30 years, things like that. And so you wonder like, how can I change my interventions to be more effective? Like, do I need to just be giving the lecture more to more people? Because it is, right? It's one of those things where like, repetition, so quote unquote, is the mother of learning. So you do wonder, like, am I talking enough? Like that, like you were saying, the information transfer, is the information just not getting through? Or is it me? Is it the way I'm communicating it? And again, right, I don't know that there's been necessarily studies looking at like more like large academic versus smaller community hospitals. Like, is there a difference in like recognition of some of these common neurologic entities? And kind of to your story earlier, where you were getting calls for Korea, it's like if I get consulted for a tremor in the hospital, in my mind, it's myoclonus and asterixis until proven otherwise, because it's usually like toxic metabolic type stuff, right? But but it is one of those things where it's like I kind of think back to the Princess Bride, Inigo Montoya. It's like you keep using that word. I don't think it means what you think it does, and kind of like the vocabulary becomes so important. And I know us as nerdologists, it definitely is one of those things where like we can be very into the semantics of like, well, technically no, it's more like this thing, not that thing. But in broad strokes, words do matter to an extent because they have different treatments, they have different prognoses, and so on and so forth. So it's hard, I think, to get across that nuance without feeding into kind of going back that underlying distaste of neurology as a specialty to non-neurologists. But what are your perspectives on that whole word vomit I just issued forth?
No, honestly, I have like my mind just went in like 5 different directions, and I'm trying to like rail in to either a single point or like keep them all in mind. So much of what you said resonates so much. So let me just say a couple points, maybe not in perfect order, but the first is I love every teaching opportunity. Like never miss a teaching opportunity. So one example is this idea of like we do these like consults in isolation. We're like, oh, patient has tremor, question mark, you go, you're like, oh, asterixis, ugh, you walk out, you're right, you know. What about bringing the team in, being like, this is what asterixis look like. This is the qualities that make it not a tremor. Here's a little, oh, the patient can't hold up their arm. Well, you can just look at the finger. Like, like you can teach these little things. And sometimes we know that people kind of learn by stories and cases. And so that's a case that maybe will stick in their mind. And maybe they'll still call you, but they'll be like, I think it's asterixis. Like, can you come and check? And then the next one will be like, oh, it's asterixis. Is there anything else we should do? And then next time you won't even hear. But the idea is like, I used to love the consult service because we got to talk to the teams, and we were trying to kind of, bring them along to our vocabulary, not to be specific, but to kind of clarify and like, and I also try to avoid the jargon because I don't think it's helpful. I think being descriptive is most helpful. The other point I'll make about the language though, is that language begets action. So when a nurse is like, this is seizure-like activity, like someone's already drawing up the benzo. And I think that is good, but it's kind of like the flip side of the negative side of protocols, right? It's like, it's the same thing as in the ED when the ED calls a code stroke and we're like rolling our eyes. We're like, really? Because when you call a code stroke, there's a protocol, and we're just like, okay, it's not even like a stroke syndrome, right? But that's, in a way, it's kind of like, if our threshold was too high, we'd miss some. And so that's right. Kind of like the flip. It comes with the territory. And same with the seizure like episodes, like our threshold has to be high. The benzo has to be drawn up, maybe not given, but maybe drawn up. And I once had this experience where I was teaching internal medicine residents because they're like, we really want help from neurology about managing seizures. And so I was like, they're like, what do you do? Like, okay, here's the case. Like, what is the first thing you do? And I was like, well, I walk into the room and I say, I'm the neurologist. And then I take out my phone and put a timer for 2 minutes. And then I press the video and then I stand at the foot of the bed. And they were like very confused because they're like, wait, what do you mean? Like, and I'm like, yeah, I mean, the nurse is like, check. I mean, okay, like I was exaggerating a little bit, but the idea being that information is like very key. It's like, that is actually the key information that I need in that moment. Is like, what does this look like? Of course, ABCs, as long as that's the patient is, breathing and okay, vitals are okay, like then you stand back. And part of it is teaching them the natural history. And so I think that the more we can like talk out loud and quote unquote, like show out loud, like even if you're with residents or you're with a med student, like bring them with you, say, like when you were saying, I observed this event, the pelvic thrusting, like it's hard with a patient in the room, but let's say you had a student with you, you could say, I notice a patient's, her eyes are, his or her eyes are closed. This pelvic thrusting is, asymmetric. Look how the arm moves in and out. Like, look at how, this and that. We're going to look at the postictal state. Is the patient going to wake up right away? Say, oh, what happened to me? Immediately speaking, immediately not confused. So like, just, pointing out to others what you're seeing, I think one teaches them, but also inspires them. Cause I mean, I think like neuro is pretty cool, and neurologists who are effective at, as you said, connecting our eyes to our mind and then connecting that to our mouth and articulating that. That's the skill set that we're practicing. As to your reach with your videos, I love that idea. I love those videos. But the thing is, like, the lesson is not like right or wrong. Like, oh, I got that one wrong. Oh, I got this one right. The lesson is like, what in the video made you think this? What in the video made you think that? Are you familiar with visual thinking strategies?
I'm not.
VTS. It's a type of arts-based educational approach where you use art to hone observation skills. And it's been applied in medicine. So the idea is you gather as a group in front of a painting and you're like, this,
I have heard of this. Yes.
Yeah, like this, and the arts educator, the educator who's in charge, standing with the group, looking at the painting, is really there to facilitate the articulation of what observations have led to a conclusion. So, for example, someone will say, "Oh, the woman on the right," and the arts educator will interrupt and say, "What makes you think it's a woman?" And they'll be like, "Oh, the figure with the longer hair." You're right. Actually, I don't know. The figure with the longer hair is wearing blue. Like you realize kind of like you really break down, and it promotes observation, articulation, and also team building and perspective taking. Because once I've shared that it's, a figure with longer hair, someone else is like, what do you mean figure? It's like I don't even see a human form. Like I see just blotches of colors. And suddenly you're like, whoa, like I thought what I saw was the truth, as opposed to what we all together break down into like just the objectivity of it. So long story short, I feel like what you've been doing is like the VTS of seizure semiology. And so how do you, so the concept is, how do you spread that? And you can go to the literature and maybe answer that. You could say maybe it's online modules. Maybe you record your lecture, you make it free. Maybe it's simulation. Like maybe what we really need is, I think it's hard to simulate seizure semiology, but like in terms of like stroke management, for example, like why don't we have routine simulation for oral emergency room providers? Things like that. Like that's not a routine thing. And I think we need to think strategically and about what will have most efficacy if we want to have the most reach.
Yeah, no, it makes sense. Being more efficacious is better, right?
To me, there's such a parallel with quality and safety in medicine, because when you learn about errors or lack of quality, it's just so shocking. It's like, how can this be? How can this be the case in our system? Like no one would disagree with improving quality, right?
Right.
And I think it's somewhere in education is that no one would disagree with the improvement of education, because that would also lead to our ultimate outcome of improved patient care, improved experiences. And so I do think taking a little bit of kind of a stance and saying like we can't just kind of rest on our laurels or say we're doing this, but we really have to do it.
And so that's an excellent point, right? I think you, like as you said, right, no one's going to say better quality is bad. And if we make the assumption that better education leads to better physicians and advanced practice providers, and then better outcomes for patients. But if we look at how education is valued within the three-legged stool of medical training, right, where we have research and clinical care as the other two legs, it's often, given very short shrift, relatively speaking.
Yeah, it's a lopsided stool. It's kind of falling over.
It's like basically two legs.
It's very unfortunate, I think, that it doesn't have the same value as you said, because I find a lot of the time it's kind of taken for granted. It's kind of like, oh, of course we teach. And it's like, yeah, we teach, like, of course, like we're going to, by natural, the fact that our residents don't know things when they're coming in, and then they work and they learn and they read and I probably shouldn't say this where I can be quoted, but we sometimes joke that, our residents are superb despite our educational curriculum. Not truly, but in the sense that we really took a hard look. For example, last year, I was one of our chief residents last year, and as part of that, had the opportunity to be part of redesigning just a little bit our educational curriculum. And we sort of took a hard look at our goals for our residents and like whether or not these were actually intentionally implemented, like intentionally designed. Sure, they were probably happening that residents got mentorship. Sure, it was probably the case that they learned the physical exam, but it wasn't intentionally designed into the curriculum. And so we introduced a few even small tweaks. And this is where I think quality improvement can guide us, right? Like these kind of quote unquote educational PDSA cycles of saying, hey, listen, our residents don't actually get formal, meaning like you can point to where it happened teaching in the neuro exam. And so we introduced a few kind of specialist high skill sessions where they had direct hands-on teaching in neuromuscular, and we did headache and occipital nerve blocks. We also did like ophthalmology and endoscopy. And then we also had like our movement disorder rounds. And so those are an example where like up until then, yes, you could certainly check the box. Like I'm sure it's happening on the ward somewhere, but there was no intentional design around when would this be, how would it be kind of, quote unquote, not marketed, but kind of like shown the value because it's actually part of the formal didactics. And we had a few other sessions as well. Like we realized we didn't have a lot, as I mentioned, around mentorship, career building. And so we introduced a series that we called the Well-Rounded Wednesday. And so our Wednesday lectures included topics among 4 categories: wellness, leadership, medical teaching, like resident as teacher, and then sort of team management and professional identity. So we then use that structure and that kind of coveted space to invite lectures or invite group work sessions or workshops. And then the final thing we did was we realized that, of course, we were graduating amazing resident educators, right? Like that just naturally happens. And we're like, well, yes, we assume that happens, but there's no formal opportunity for residents to teach or no formal requirement. And so we created small group sessions where a third year teaches the first years. And so every third year graduating can say, yep, in fact, I led a small group session. I gave a small group lecture. Like that's part and parcel when we say we're graduating the type of well-rounded neurologist we want to graduate. Well, we're giving them research training, we're giving them clinical training, but where's the educational piece? And that was kind of my bias, and that's sort of the role myself and my co-education chief brought in last year.
Excellent. Yeah. That is something I know when I'm mentoring medical students a lot is they'll, want to know like what kind of residency program am I looking at? And, at the one end, we have places like MGH where there is, a multitude of subspecialists and resources and all that. And then on the other side, there are, smaller programs that have maybe 2 to 4 residents per year and maybe no fellowships at that institution. And so it's like, what do you envision for your career? Do you see yourself like one of my former residents Shout out to Dr. Sarah Liston if she ever listens to this. But she is a neurologist in Montana, and she is the only neurologist in 100 miles. And right, so she can call people up for advice, but if she needs them to see somebody, that's a haul. So you really have to think about, like, where do I see myself in my career, not just in my medical training, but am I going to be like a clinician researcher, or do I want to just take care of patients in a rural area or an underserved community or things like that? Because different places may provide you with kind of a differently weighted skill set, and so you kind of have to think about that to an extent. But yeah, it is one of those things where we all want to graduate, well-rounded physicians, but it's definitely a different path there depending on the environment.
I agree with you that the environment can impact you. And I think what I would focus on a little bit is like role modeling, and this idea that we just want people to know that this is this is a path if you choose to follow it. What I would sort of say is,
right,
I think that teaching is a fundamental skill set that we should be teaching our residents, and we should be teaching people as they come up through neurology training, because you mentioned your former mentee. Like, I'm sure she's having to educate PCPs in her region about referrals or her patients and things like that. And so for her to have education as a skill set, even at a basic level, being an effective clinical teacher in a busy clinical environment, that's like a one type of skill set. For those who gather a little bit more interest, like the stone gathering a little bit more moss, is like, we want them to know that there's places they can go. There's resources, like you can go to educator training programs for residents, or as a faculty, the Macy Institute comes to mind. It's one that offers training for clinician educators. And then I think more broadly, I think those of us who are like committing a more major part of their career to that's where kind of that advocacy piece comes in around representation, equity, like value of this as a career in balance with the other domains of a department, that like we're committed not just to research and clinical, but to education. And I think I think we're making some progress there. We're moving some ground. I think, and for me, it's sort of like, when you're at the forefront of something like this and you're pushing, it's helpful to think of like those that are coming behind you. It's helpful to think that, like, I want others to know that, pursuing, if not that they have to, but if this is of interest, they don't have to turn down that interest, or they can make a career out of it. I remember at the education room, even that sort of role modeling was very inspiring for a lot of the junior trainees, saying like, oh, I thought the only way you could do education was like to be a program director. And like, that's great, but not everyone wants to do essentially educational administration. Some want to maybe work more on curriculum innovation, for example. And sometimes those roles overlap. And I remember one of the trainees was like, we should have like a careers night. And I know you're talking about what's your mix of the three, and I'm like zoning in on education, being like, well, within education also, what's your mix? Like, are you a PD and you do some research, or you maybe serve on a national committee, or you're super interested in simulation and you do simulation across different domains, or maybe you work with the emergency room, and because you're not so focused on neurology, you're more focused on the education. So even within that, there's lots of roles, and I think the more we can support that diversity, find that spark that motivates an individual and support them, I think the more creativity and like good outcomes we're going to have.
No, I think that's absolutely right. It kind of goes back to what you said earlier about kind of educating the educators and that whole downstream cascade. So I think it is super important to make sure, because those graduates are going to go out there, they're going to teach more people, and their students will teach more people, and so on and so forth down the line. And it becomes like one of these things where you have these like chains of people, like, oh, so-and-so was trained by, Dr. X, and, they were an amazing physician, and I learned all these tricks and things like that. And it is right. We can't get away from kind of that apprenticeship mold to an extent, just because it is such a relatively small community. And you like almost have this, to borrow something from the Christian community, this apostolic succession of neurology training. and it's very fascinating sometimes when you see like where I am, we've got Hans Luters up in Cleveland, who's kind of like, this legend in epilepsy. And so we run into his trainees, and they have all these little, kind of nuances that they pick up from him from the last, so many decades. And it is one of those things where there's like almost schools of practice in neurology that you can trace back to certain like kind of founding physicians. And it's very fascinating in a way to kind of see that evolution or these different schools of thought evolve over the decades.
I'm very fortunate to have trained at Mass General Brigham when Dr. Samuels was alive, and he was one of my early mentors and for so many of us. And recently when we were in the inpatient service, one of the residents he's like, I'm now calculating how early it is in the morning when someone first mentions, like Marty used to. And he's like, yesterday was 8:01 and like today it's like 7:39, like 5 minutes into our morning report. And it was just kind of it's bittersweet to have that memory, but it's so true that people pass on stories and pass on exam findings, or say like, oh, I always do this, and X person, taught me that. Or whenever I'm like doing a really good neuromuscular exam, in my mind, there's like the person who taught me that is like scrutinizing my, whether I'm like isolating the joints well enough. And so there is a kind of heritage there. And I think that that's a big part of, education as well, is really the relationship building that is sort of sacred between a teacher and a learner. And so I think that that's kind of where as I mentioned, I think at the beginning, kind of where I get the drive and the motivation to keep it going. Because it is fulfilling to see someone learn, and it's fulfilling to, see them teach you something back. In fact, and it's really a full circle.
Mm-hmm. And I think I might have mentioned this before we started recording. I was calling up one of my former residents who she's now an MS specialist, and I was asking for her advice. So it is right. It's come full circle. I'm reaching out to the people I helped educate, and now they have skills that I don't, or experiences that I don't, and they're able to help me learn how to take care of challenging patients and things like that as well. And it is right. It's now that I'm kind of moved into that stage of my career, it's a little surreal almost to see people, because I remember them as these junior residents, and now they're out there independent, practicing, making complex decisions. And it's like, it's very satisfying, and almost like I can't believe that, I had a hand in any part of this. So it is very satisfying to kind of look back on those aspects of your career.
I think as an educator, like you've got it, like you are a learner and you're a teacher too, and you're kind of both. And the more you're open to that, I think the better, the more effective you'll be. Because like, for example, I love the book, Thanks for the Feedback. And I think the first sentence in it is like, everything is feedback. And it's just this idea that like, you kind of choose which data to pull in. And like, if you're giving a lecture, you're giving a session, like confused quizzical looks, like, you may have to adjust, or you may have to adapt to every learner. And the idea is like, you can't even guarantee that it will have the same land the same way or have the same impact. And so constantly being open to change, to adapting if you need to the feedback. I think those are important skill sets that you get as you think around as you think about becoming a teacher. And I think that those are also, like, we haven't really talked about patient education, but that's something we do every day in our clinic. And that also has to, to be most effective, it's better if you don't have a boilerplate spiel, but you have something that's adapted to the individual in front of you.
I mean, I can't just print out the epic AVS after visit summaries and just give that to the patient and walk out of the room.
Well, my favorite quote is, the biggest misconception about communication is that it happened.
Ooh, that's cutting.
When you asked me about, like, I know when you asked me, like, is it my lectures about communication? I was like, yeah, I mean, you can print it out, but that doesn't mean anything.
Right. It's one of those things.
Doesn't mean the community.
Right. It's like, I sent this email or I recorded this lecture, but did anyone listen to it? Yeah, it is. It is one of those things where it's like, if no one's listening, if no one's paying attention, it never happened.
I think the most like impressive and satisfying thing is not so much like giving the lecture, because then like you're right, you have no idea, but like maybe a few days later the student is like using what you taught them. You're like, yeah. Like
that is satisfying. Yes.
I remember there was, I was on service with some medical students, and then later that month I was running the simulation session, and I was obviously observing. I was kind of like a participating in the simulation, and the student was like, "Well, like this onset was acute, and there's a focal finding of the right-sided ataxia, so we have to consider stroke." And I was just like, "That's beautiful." Just beautiful. It wasn't just it was just like his reasoning was very much like we had talked about the whole rotation. And so it was just nice to see that education in action.
Excellent. So we've talked a lot today about different ways of educating, needs for education, needs for educators. So I want to say thank you again to Dr. Galina Gheihman. Thank you so much for coming on today. If people want to find you online, if they want to check out your work, where should they look?
Good question. I think the best is probably to email me. I don't have an online presence. Maybe that will change after this, but I'm happy to include my email in the show notes. And you can also catch me hopefully at the resurgence of the education room at future AAN conferences. And just want to thank you again for taking the time to really, have us, I guess, kind of put forward a call for educators and education and the exciting opportunities that neurology education is going to allow us in the future.
I'm very excited about it as well. And if people want to find more neurotransmitters content, you can find me on Twitter/X at Dr. Kentris or at neuro_podcast. And you can also find more of our content on the neurotransmitters.com at our website. Thank you again. I really appreciate you taking the time.
Thank you.